All right, welcome. Today we're doing a real deep dive into the pharmacology of bone health. Now, to really get how these drugs work, we first have to understand the incredible living tissue they act upon, bone itself. So let's jump right in. So, here's the game plan for this explainer. We're going to start with the absolute basics, what bone is made of and the cells that live there. Then we'll see how those cells work together in what's called the remodeling cycle. From there, we'll meet PTH, the body's master calcium regulator, before getting into the core pharmacology, the drugs that slow bone loss, some other key agents, and finally, we'll see how it all comes together in a real-world treatment strategy for osteoporosis. Okay. First things first, before we can talk about the drugs, we need to understand this stage on which they perform. So let's take a close look at the composition of bone, this amazing living tissue that's at the very heart of how our body manages calcium.
You know, it's pretty amazing when you think about it. Bone is this incredible composite material. About 3/4 of it is inorganic stuff, mostly these crystalline calcium phosphate salts called hydroxyapatite. This is what gives bone its incredible hardness and rigidity. The other 25%, well, that's the organic part. This includes the bone cells themselves and the osteoid matrix, which is basically a framework of type 1 collagen that gives bone its strength and flexibility. And this is super important. This whole structure acts as the body's main calcium bank, storing something like 99% of our entire supply.
Now, let's meet the cast of characters, the key cells that run the show. First, you have the osteogenic cells. Think of these as the bone stem cells. They can become our bone builders. And those builders are called osteoblasts. They are responsible for laying down new bone. Now, once an osteoblast gets trapped in the very matrix it just created, it matures and changes its job, becoming an osteocyte. These are the watchmen, the stress sensors that constantly monitor the bone's health. And finally, you have the osteoclasts, these huge multinucleated cells that are like the demolition crew, responsible for resorbing or breaking down old bone. Okay, so we've met our cast of characters, the builders, the sensors, and the demolition crew. Now let's see how they all work together in this constant, ongoing process they manage called bone remodeling. So this is how it all plays out, this dynamic cycle of bone remodeling. It all starts in a quiet, resting state, where the bone surface is just covered by these bone-lining cells. Then the process kicks off with resorption. The osteoclasts, that demolition crew, arrive on the scene and start breaking down a section of old bone, digging out a little pit. After that comes the reversal phase. The osteoclasts leave, and the site gets prepped for new construction. Finally, we have the formation phase. The osteoblasts move in, lay down a new osteoid matrix, and then that matrix slowly mineralizes, filling in the pit and making the bone whole again. Okay, let's just quickly recap that so it really sticks. Here are those 4 key steps laid out. We begin at the resting state. Then we move to resorption by the osteoclasts, we transition through the reversal phase, and we finish up with formation and mineralization by the osteoblasts. And remember, this cycle is happening all the time, all over your skeleton to fix tiny bits of damage and keep your calcium levels just right. So this brings us to why all this matters clinically. What happens when this beautifully balanced cycle gets thrown off? Well, that's when you can get osteoporosis. In this condition, the scales are tipped. The bone resorption by osteoclasts starts to outpace the bone formation by osteoblasts. And the result? You get a progressive drop in what's called bone mineral density, or BMD. This makes the bones incredibly fragile and shoots the risk of fractures way up. This is the exact condition that all the drugs we're about to discuss are designed to treat. All right, to figure out how we can actually use drugs to influence this cycle, we first have to understand the body's own master switch. So let's meet the main hormonal regulator of calcium balance, parathyroid hormone, or PTH, and check out its really important and surprisingly complicated role. Okay, let's get into the nitty-gritty of PTH. It's an 84 amino acid peptide hormone, and it does its job by acting on G protein-coupled receptors. Now, its release from the parathyroid glands is super tightly controlled by these special receptors called calcium-sensing receptors, or CASRs. It's a classic negative feedback loop. If your plasma calcium gets too low, PTH secretion gets a boost. If calcium gets too high, secretion is suppressed. And check this out, there's a cool clinical tie-in. A drug called cinacalcet is a calcium mimetic. It actually mimics calcium, tricking these CASRs into activating to shut down PTH secretion, which is really useful for treating conditions like hyperparathyroidism. So what happens when PTH gets released into the bloodstream? Well, it acts on 3 main targets to get plasma calcium levels back up. First, it has a really fast effect on the kidneys. It tells them to reabsorb more calcium and at the same time get rid of more phosphate. Its effect on bone is a bit slower. There, it ramps up osteoclast activity to break down bone, which releases calcium and phosphate into the blood. And finally, it has an indirect effect on your gut. It tells the kidneys to activate vitamin D, and active vitamin D is what allows us to absorb more calcium from our food. The end result of all these actions? Plasma calcium goes up. Okay, now we get to something that is absolutely critical to understand, and it might sound a little weird at first. It's the dual nature of PTH on bone. If you have continuous, high levels of PTH, it has a catabolic, or breakdown effect, and it does this indirectly. The PTH tells osteoblasts to release a signal called rank L, and it's that rank L that activates the osteoclasts to resorb bone. However, and this is the amazing part, if you give PTH in intermittent, low doses, it does the complete opposite. It becomes anabolic, or building. It directly stimulates osteoblasts to differentiate and grow. This leads to a net increase in bone formation. This is called the anabolic window, and it's the entire scientific basis for using PTH drugs to treat severe osteoporosis. Okay, that brings us right into our first major class of drugs. Since osteoporosis is often a problem of too much resorption, a key strategy is to just slow that process down. So let's dive into the anti-resorptive agents. As their name suggests, they work by putting the brakes on osteoclasts.
First up, we have the bisphosphonates. Now, chemically, they're basically synthetic cousins of a natural compound called pyrophosphate. But there's one tiny game-changing difference. See, pyrophosphate has a phosphorus-oxygen-phosphorus bond, a POP bond, which enzymes in our body can easily break down. Bisphosphonates, on the other hand, have a phosphorus-carbon-phosphorus, or PCP bond. That carbon atom in the middle makes them incredibly tough and resistant to being broken down. This means they can stick to the bone mineral and just hang around for a really, really long time.
So how do they actually work once they're stuck to the bone? Well, there are actually two different mechanisms. Let's start with the more powerful class, the nitrogen-containing bisphosphonates, or NBPs. When an osteoclast starts to resorb a bone that has an NBP attached, it basically eats the drug. The NBP then gets inside and blocks a key enzyme called farnesyl pyrophosphate synthase. This messes up a whole pathway, the mevalonate pathway, and prevents something called protein prenylation. Without this process, the osteoclast can't make the little lipid anchors it needs for its internal structure, and it just stops working. Now, the other class, the non-nitrogen-containing ones, work differently. The osteoclast metabolizes them into what are essentially toxic versions of ATP, the cell's energy molecule. This poisons the cell's energy systems and pushes it into apoptosis, or programmed cell death. So let's talk about the clinical side of things, what you actually need to know. We have our two main classes, the nitrogen-containing ones, like alendronate, and the non-nitrogen ones, like atrigenate. And there's a clear potency difference. The ones with the nitrogen in a ring structure are the strongest. From a drug in the body perspective, they are absorbed very poorly when taken orally. They don't stick around in the blood for long, but, and this is the key part, once they get into bone, their half-life can be over 10 years. Now, for side effects, the oral versions can cause GI upset, and there are two rare but very serious risks: osteonecrosis of the jaw, or O&J, and atypical femoral fractures. Because of that O&J risk, a dental checkup is always recommended before a patient starts on one of these. Okay, let's shift gears to our next anti-resorptive target, which is this really important signaling pathway that the body uses to control osteoclasts naturally. The bone-building osteoblasts produce a signal molecule called rank ligand, or rank L. This rank L then binds to its receptor, called rank, which sits on the surface of those baby osteoclast cells. This binding is basically the go signal. It tells them to grow up and become active, bone-resorbing osteoclasts. Now, to keep all this from getting out of control, the body has a built-in brake. The osteoblasts also secrete a decoy receptor called osteoprotogerin, or OPG. OPG basically intercepts rank L, grabbing onto it so it can't bind to rank. This stops osteoclast formation in its tracks. So you can probably see where this is going. If we could create a drug that mimics that natural brake, OPG, we could put a serious stop to bone resorption. And that's exactly what denosumab does. It's a monoclonal antibody, an engineered protein that is designed to be a rank L inhibitor. It binds to rank L, just like OPG does, effectively taking it out of commission. This dials down osteoclast formation, differentiation, and survival. Denosumab is given as a shot under the skin every 6 months, and it's a great option for patients who can't take bisphosphonates. All right, let's talk about a couple of hormonal approaches. For a long time, we had hormone replacement therapy, or HRT. This just involves giving estrogen, which does a good job of decreasing bone resorption. But it comes with a lot of baggage, serious risks like blood clots, heart disease, stroke, and a higher risk of breast and endometrial cancer. This led scientists to develop something smarter, selective estrogen receptor modulators, or SERMs, like relaxafen. And the key word here is selective. It acts like an estrogen agonist, an activator, in bone, which is what we want. But it acts as an antagonist, a blocker, in the breast and endometrium, which is protective. So how on earth does it do that? How can it be selective? Well, when relaxafen binds to the estrogen receptor, the final shape of that drug receptor complex is just a little bit different than when estrogen itself binds. And that tiny difference in shape is everything. In bone cells, that specific shape recruits helper proteins called coactivators, which turn on the genes that protect bone. But in breast and uterine cells, that same complex recruits a different set of proteins called co-repressors, which shut those genes down. It's a really clever way to get the good effects in one tissue while avoiding the bad effects in others. I should mention, though, that SERMs do still carry an increased risk of blood clot. All right, we've covered the real heavy hitters in the anti-resorptive world. Now let's look at some other key players that have important, though maybe more specialized, roles in managing bone health. Next up is strontium ranelate, and this one is really unique because it has a dual mechanism of action. The strontium atom is very similar in size to a calcium atom, so our bodies can actually incorporate it into bone. And once it's there, it seems to do two things at once. It stimulates the osteoblasts to build more bone, and it encourages the osteoclast to undergo apoptosis, which decreases resorption. So it's both anabolic and anti-resorptive. Sounds great, right? Well, there's a major catch. Its use is now highly restricted because of a demonstrated increased risk of heart attacks. So now it's only for very specific, high-risk patients who have no cardiovascular risk at all. And of course, we can't talk about any of this without talking about the absolute fundamentals, the building blocks of bone health. First, there's vitamin D. It's essential for us to be able to absorb calcium from our intestines. We can get it as D3, which our skin makes from sunlight, or D2 from some foods. The recommended daily intake is 600 international units. And then there's calcium itself, which you can get from oral supplements like calcium carbonate. To help manage osteoporosis, the target is usually over 1,200 milligrams per day. Okay, deep breath. We've covered a ton of ground: the cells, the cycle, the master regulator, and all the major drug classes. Now, for our final section, let's pull it all together and look at a clear, step-by-step treatment strategy based on current clinical guidelines. So here's how this all fits together in a clinical treatment plan. Step 1 is the foundation for absolutely everyone. Make sure the patient is getting enough calcium and vitamin D. Step 2 is the first-line drug therapy, which is almost always a bisphosphonate. After 5 years, you reassess if they still need it. If a patient can't take or doesn't tolerate bisphosphonates, we move to Step 3, the second-line therapy, which is denosumab. And finally, Step 4 is for special cases. You might consider a SERM for someone who is also at high risk for breast cancer. The anabolic PTH drugs are reserved for very severe osteoporosis. And like we said, strontium is a last resort for very high-risk patients with zero cardiovascular risk. And that, everyone, brings us to the end of our deep dive. We've seen drugs that slow down the demolition crew and drugs that boost the construction crew. So this leaves us with a big question for the future. As we get even better at understanding the intricate communication between these cells, how might the next generation of therapies go beyond just pushing one side of the scale and instead learn how to truly reset the entire homeostatic balance of bone remodeling itself? It's a fascinating area to watch. Thanks so much for joining this explainer.